So, very good morning, good afternoon, good evening, everyone. Today, we are going to start another topic in cardiovascular pharmacology, that is your diuretics. So, what are diuretics? What are their mechanism of actions? What are different drugs which comes under diuretics? These all things we are going to discuss. So, what actually diuretics are? Diuretics are those agents which will increase the agents which increase the output of urine. So, the drugs which increase the output of urines, these drugs we call diuretics. So, diuretics are useful in various cardiovascular disorders like in CHF where edema is formed. So, we are giving the diuretics in hypertensions where you want to decrease preload as well as the afterload, we are giving the diuretics to the patients. So, what are the diuretics? Diuretics are those agents which increase the output of the urine. So, first you have to understand how urine is formed. So there is a in kidney, there is a functional cells, these are we call nephrons, and nephrons, there are millions of nephrons in our kidney and they helps in the formations of urine. So, how nephrons form the urines and how these diuretics agents are increasing the urine output, that we are going to discuss. So, first thing is, we have discussed many times in cardiovascular systems, this is your left atrium, left ventricles, right atrium, right ventricles, and there is a valve between these atrium and ventricles. So, there is a cardiac output, and approximately cardiac output is your 5 liters, right? 5 liters, and out of the 5 liters 20% of the blood is going to the renal systems. So, this is output is your cardiac output is 5 liters, and out of 5 liters 20% of it, 20% is going to your renal systems. So, 20% of 5 liter is how much? It's simple mathematics. 20% of 5 liter is your 1 liters. So, 1 liters blood is going to the renal systems, right? So, 1 liters. So, 1 liter blood is going to the renal systems, and there are a nephron, and nephron have a different parts of the nephron is your proximal convoluted tubule, there is a loop of Henle's, and there is a DCT, distal convoluted tubules, and there is a collecting ducts. So, but nephron is collecting or that filtrate. So, the unit which is doing the filtration is we call Bowman capsules, right. So, there is a in kidneys, this is your blood circulations, and as I said, how much blood is going to there? 20%. 20% of your cardiac output. Cardiac output is 5 liter. 20% of 5 liter is 1 liter. So, if you see the in 1 liters blood, how much will be your plasma and how much will be your cells, right? So, 60% will be your plasma and 40% is your cells. Oh, sorry, this is your plasma. So, if I ask, if your 1 liter blood is going to the renal systems, in 1 liter blood how much is the plasma and how much is cells? So, of course, there is a 600 ml will be your plasma and 400 ml is your cells. So, cells are not going to filter out, right, in normal physiological conditions. If someone has some pathophysiology or pathological condition, in that cases you can detect the cells in the urine, but normally your plasma is going to filtrate. So, out of 1 liter how much going to filtrate? Your 600 ml is going to filtrate here, 600 ml plasma is going to filtrate, right. So, again there is a 20% of 600 ml is going to filter. So, 20% of 600 ml is how much it will be? 120 ml. So, 120 ml per minute, we are talking about per minute. So how much filtration is going through in the Bowman capsules? There is a 600 ml plasma is going to filters, and 20% of this is you are getting in the filtrate. So 20% of 600 ml is 120 ml. So that's why if we talk about GFR, glomerular filtration rate. So glomerular filtration rate is 120 ml per minute, right? So how you are getting it? So you are getting like this. So there is a 5 liters, 20% is 1 liters, and 1 liter is going to the your renal systems, and in 1 liter blood your 40% will be your cells and 60% is your plasma. So cells are not going to filter down, your plasma is going to filter down. So 60% of 1 liters will becomes 600 ml, and out of 600 ml your 20% is going to filter. So 20% of 600 ml is 120 ml. So that is your we call GFR, glomerular filtration rate, right? So once this urine is your filtration is happens in the Bowman capsules, right? So for example, this is your Bowman capsules. Here is filtration is happening. So there is your nephron. So nephron has different parts. And then there is a collecting ducts. This is your urine formation, right? So if we talk about nephron, that is the functional units of kidney. So nephron have your PCT. PCT we call proximal convoluted tubule. There is a loop of annals. There is a descending loop of annals. There is a ascending loop of annals, right? Then there is a DCT, that is your distal convoluted tubules, DCT, and then there is a collecting ducts, right? So as I said, आपका जो कार्डिक आउटपुट अप्रोक्सीमेटली कितनी है? कार्डिक आउटपुट इज योर 5 लीटर्स, राइट? 5 लीटर में से आपका 20% जो है दैट्स गोइंग टू द रीनल सिस्टम्स. तो 5 लीटर का 20% कितना हुआ? 1 लीटर. 1 लीटर में फिल्टर कौन सा होगा? सेल्स तो फिल्टर नहीं होंगे नॉर्मल फिजियोलॉजिकल कंडीशंस में, तो उसमें 60% आपका प्लाज्मा है, 40% आपका सेल्स हैं. तो अगर 1 लीटर अगर ब्लड रीनल सिस्टम पे जा रहा है तो उसमें 60% कितना हो गया? 600 ml. तो वो 600 ml आपका फिल्टर होगा, उसका 20% you will get the filtrate. So 20% of 600 ml is 120 ml. So 120 ml you are getting, right? 120 ml per minute. That is we call glomerular filtration rate. So when you are getting this is moving through these parts. So here is the channels, and finally you are getting the urine, right? So this where you are getting this, there is a 99.9% is going to reabsorb back to the systemic circulations. So in proximal convoluted tubules, some of the channels are there which will do the reabsorptions of the ions, water molecules, right? There are ion channels here in the loop of annals. There is ion channels in the distal convoluted tubules. Here is also the ion channels. So your whatever you are getting the filtrate, it's going to reabsorb back to the systemic circulations. And the diuretics are those drugs which inhibit the reabsorption of these ions or these water molecules. And because your diuretics, what are diuretics? Diuretics are those drugs which increase the output of the urine, which increase the excretion of sodium, that we call natriuresis, right? So how they will increase? They will increase by blocking these channels. When there is a no reabsorption will happens, so your urine amounts will be increased, right? So normally what happens? Normally whatever the filtrate you are getting, when your filtrate is passing through the different parts of the nephron, it going to reabsorb back to the systemic circulations, right? But if you want to increase the urine output, you can inhibit these channels. So your urine output is going to be increased and reabsorption is going to be decreased. That's why I said one thing, diuretics are useful for the CHF patients, congestive heart failure patients. So if you remember, we talk about CHF. In congestive heart failure patients, what happens? Your ventricles are not contracting properly. By that, your preload and afterload is increased, right? Preload is the load which is created by the blood which are in the ventricles, right? So afterload is when your ventricles are contracting, that time what is the load on the heart created by the blood. So these all load, if you want to decrease it, you want to remove these water molecules, because your renin, angiotensin, aldosterone system during the compensatory mechanism in the CHF, it's also going to reabsorb more sodium and waters, and more reabsorption of sodium and waters will worsen the condition of the patients, right? So you want to give diuretics which will decrease the preload as well as the afterload. So how they are decreasing the preload and afterload? They are inhibiting the reabsorptions of these, and if reabsorption is less, so your load is going to decrease. So one by one we are going to discuss how it happens. So first we are going to discuss the drugs which are acting on first part of the nephron, and first part of the nephron is PCT, that is we call proximal convoluted tubules. Proximal convoluted tubules. So the drugs which are acting on the proximal convoluted tubules, the drug, well-known drug is acetazolamide. Acetazolamide. Acetazolamide is the drug which is acting on the proximal convoluted tubule, and it's a diuretic agent, right? So how it react? What is its mechanism of actions? So mechanism of actions of the acetazolamide, which is the drug which is acting on the proximal convoluted tubule, the drugs which are acting on the loop of Renals, I can tell the classification of the drugs. The drugs which is acting on the loop of Renals, the drugs are your loop diuretics, that we call loop. Why we are calling loop diuretics? Because they are acting on the loop of Renal. So it's simple, we call it loop diuretics. And loop diuretics example is furosemide. Furosemide. Loop diuretics. Loop diuretics are those drugs which act on the loop of Renals. There is a drugs which are acting on distal convoluted tubules. This is another part of your nephron. So the drugs which are acting on distal convoluted tubules, we call thiazide diuretics. Thiazide diuretics. Example is chlorothiazides. There are many drugs under thiazide diuretics. Then there is a drugs which are acting on the collecting ducts or later part of distal convoluted tubules. These we call potassium sparing diuretics, right? These are the drugs which inhibit the action of aldosterone. You remember during the RAS system, renin, angiotensin, aldosterone system, there is a release of aldosterone from adrenal cortex, and aldosterone is acting on your distal convoluted tubules or collecting duct part and going to do the reabsorption of sodium and water. So in this case, you don't want a reabsorption of sodium and water. Diuretic are those drugs which will do the excretion of sodium and water from the body. So there is a drugs which are inhibiting the action of aldosterones, right? So these are all are the drugs which comes under classifications of diuretics. So one by one we are going to discuss. So first one is the drugs which are acting on the proximal convoluted tubules. So if you see the proximal convoluted tubules, this is your filtrate which you are getting from the Bowman capsules, right? And you are getting 120 ml per minute. Filtrate of what? Filtrate of plasma. Plasma is filtering out, right? You are getting it. Now it enters into the proximal convoluted tubules, and in proximal convoluted tubules there is a two parts. One part of the membranes, that is luminal side, another one is basolateral side. So this is the luminal side, this one luminal side, right, and this one is your basolateral side. Basolateral side. Okay. So what happens in proximal convoluted tubules, there is a channels for your sodium, reabsorption of sodium and hydrogens, and hydrogen is a exchanger. So this is be called antiport system. There is a symporter or antiport. So these are the antiporter, means एक आयन आपका बाहर से अंदर की साइड आ रहा है, एक अंदर से बाहर की तरफ है, तो दिस इज एंटीपोर्ट. अगर दोनों एक साइड मूव करेंगे दैट वी कॉल सिम्पोर्टर. सो इट्स एंटीपोर्टर, राइट. सो सोडियम इज गोइंग टू एब्जॉर्ब and with sodium your hydrogen is exchanging, right. So sodium is going to absorb, it enters inside, this is your intracellular side and this is your basolateral side, then there is a systemic circulations, this is your blood, systemic circulations. So normally what's happening, as I told you, whatever filtrate you are getting from here, when it passes through the different parts of the nephron, it's going to reabsorb back to what, back to blood, that is systemic circulations. So sodium ions, whatever you filtrate are getting, sodium will be reabsorbed through sodium hydrogen exchanger. So sodium will enter here, and you know many times we have discussed every cells on their cell membrane there is a very important pump, and that pump we call sodium. 3 sodium will go outside and 2 potassium will comes inside, and this pump is sodium potassium ATPase. ATPase is the enzymes which will help during this movement. So whatever sodium is going to enters, it's going to be moved from the cells with this exchanger, with this pump, that will be called sodium potassium pump. So 3 sodium will go outside and 2 potassium will come inside, right. So this sodium will go back to your systemic circulations, right. Got it. So there is a when this is a filtrate, so there is a bicarbonate ions also comes, HCO3, right. So these bicarbonate ions combine with this H positive ions. So I can make this one little bit bigger for your understanding, right. So this H positive ions is combining with bicarbonate. I am talking about normal process, right. So it will do the formations of H2CO3, carbonic acids, right. This carbonic acids, this is your luminal side, right. This one is your luminal side and this one is your vasolateral side. This carbonic acid H2CO3, there is enzymes, that enzymes we call carbonic anhydrase. So what this enzyme is going to do? This enzyme is going to convert these carbonic acids into carbon dioxide and water molecules. Carbon dioxide and water, right. And if you remember, when we talk about what are the different mechanisms by which molecule crosses the cell membrane. So one of the mechanism I told you, molecule can pass the cell membrane through passive diffusion, facilitated diffusions, active transport, inactive transport, primary active transport, secondary active transport, and this is an example of your primary active transport, right, where you are working against the concentration gradient. Then we have talked about passive diffusion, and if you remember, I told you the molecules which are small molecules, the molecule which are uncharged molecules, these are crossing the cell membrane through the process of simple passive diffusion, which is dependent on the concentration gradient. So this carbon dioxide is your small molecules, it's a uncharged molecules, so it will cross the cell membrane and enter into the cells. Carbon dioxide will enter, right. And this carbon dioxide inside the cells, inside this cytoplasm, there is a water is also there, so it will combine with water molecules and do the formations of H2CO3, carbonic acids. And this carbonic, there is enzymes, that is the carbonic anhydrase, same enzymes which are working here, and this is going to break down into H positive, this is H positive, and HCO3 negative, and this HCO3 negative, there is a transporter which will transport this HCO3, and H positive is utilized. H positive is going to move from inside to luminal side, right? This is a normal process. Again, I am repeating, this is happening in your proximal convoluted tubule. This is the first part of your nephron. So you are getting the filtrate, your plasma is filtered out, and it reached to the first part of the nephron, and in the first part of nephron there are various ion channels which helps to do the reabsorptions. So one of the ion channel is your sodium and hydrogen exchanger. So your sodium is going to be, the sodium which comes out, so it's going to be reabsorbed back to your systemic circulation, because sodium have a various functions. So how it's going to reabsorb this sodium? There is a sodium hydrogen exchanger is the pump which is present at the luminal side. So sodium will going to enter inside the cells, and on the basolateral side there is a sodium potassium exchanger. So sodium will going to 3 sodium will go outside, 2 potassium will comes inside, right? And these hydrogen is going to bind with carbonic bicarbonates and makes the carbonic acid. This is your carbonic acids, and this carbonic acid is going to convert into carbon dioxide and water molecule with the help of enzymes. Enzyme name is carbonic anhydrase. And this carbon dioxide, this water is going to be next part and going to be through the collecting ducts. But this carbon dioxide is going to enter again inside the cells. It combines with the water, and with the help of carbonic anhydrase enzymes, it's going to convert into carbonic acids. Then it will be split out into hydrogen ions and SCO3 negative. And SCO3 negative, there is a channels. This is the process. Now we are talking about the drugs which increase the output of the urine, which increase the excretions of sodium ions, which increase the excretions of water molecules. So how these drugs are helpful, or diuretics? The diuretics which act on the proximal convoluted tubules are your carbonic anhydrase inhibitors. These drugs are going to block this. This drug is going to block these enzymes, right? So where it going to block? Here it going to block. One, here it going to block. What it going to block? These drugs. These drugs is going to block your carbonic anhydrase. And what is carbonic anhydrase? Carbonic anhydrase is a enzymes which is converting your carbonic acids into water and carbon dioxide, which is combining carbon dioxide and waters and doing the formations of carbonic acids. So your drugs, the drugs which are acting on this proximal convoluted tubule and carbonic anhydrase inhibitors, the drug is acetazolamide, well known drug, acetazolamide. Acetazolamide is a drug which is going to block carbonic anhydrase inhibitors. अब होगा क्या? If you are blocking the carbonic anhydrase inhibitor, what will happen? Your carbonic acids will not going to convert into water and CO2. Water and CO2 will not form. Your CO2 and water will not combine. Your H positive, do you think this pump will work properly? No, right? Because H positive are less. So H positive are less, this pump is going to be affected. This pump is going to be affected, and if this pump is going to affected, what will happen? The H positive ions is going to decrease. So H positive ion is not available to combine with the bicarbonates. So ultimately what happens in next part of the nephron? Which ions will move? Your sodium ions as well as bicarbonate ions. So these ions are going to move further because this pump is going to affect, right? If this pump is going to affect, your sodium is not going to be reabsorbed. Sodium is not going to reabsorb, sodium is going to be excreted out. And that excretion of sodium we call natriuresis effect, right? Your sodium is going to excrete it out. Your bicarbonate, because bicarbonate hydrogen ions are not available to convert into carbonic acids, carbonic anhydrase is inhibited, so your carbonic bicarbonates are going to be excreted out to the next part of the nephron. So this is your carbonic anhydrase inhibitors, which is going to inhibit the reabsorption of sodium and inhibit the reabsorption of bicarbonate ions. So your sodium and bicarbonate ions are going to move from other part of the nephron, and finally it's going to be excreted out in the urine, right? But one more thing is, with respect to these carbonic anhydrase inhibitors, these are also useful particularly to reduce the aqueous humor productions in the eye. So carbonic anhydrase is also there, and they do the formations of aqueous humor, and if more aqueous humors are formed, it can increase the intraocular tensions. And you know, there is a one disease, that disease name is glaucoma. In glaucoma is a disease in which your intraocular tensions is going to increase much more. So we have to give such kind of drugs which will decrease the intraocular tensions, and one of the drugs useful are your carbonic anhydrase inhibitors. Not acetazolamide, there is a dralazolamide which you can use topically, you know. There is a different drugs, but those drugs are carbonic anhydrase inhibitors which we are using in for the management of glaucoma as well. Regarding contraindication, these carbonic anhydrase inhibitor you have to avoid to use the persons who is suffering from liver disease. So if the patient is suffering from liver disease, particularly, you know, there is chances of hepatic coma. If you are using these carbonic anhydrase inhibitors in the patients with liver disease, its liver is not working properly, so it can chances of hepatic coma. How it happens? Because if your liver is not working properly, so there is a ammonia is normally converted into urea by your your liver, and it will be excreted out, right? But if your liver is not able to convert this ammonia into urea, so what will happen? Ammonia will comes here, right? If ammonia is there, so if your these pump is working properly, then what will happen? This ammonia will combine with H positive ions and convert into ammonium ion, NH4 positive, and this NH4 positive is going to excrete it out from the urine because it's a positive charge, ionic, so it's not going to reabsorb. But if the patient is of liver disease, you are giving it carbonic anhydrase inhibitors. So in that cases, what will happen? In carbonic anhydrase inhibitors, do you think H positive ions are available here? No. So if H positive ions are not available, so your ammonia will not convert into ammonium ion, and this ammonia will going to reabsorb back, and it reaches to a systemic circulations. It can cross your blood-brain barrier, and it can result in hepatic coma as well. So that's why you have to be avoid the use of, it depends upon what grade of liver disease the patients have. If the patients have severe grade of liver disease, so you have to be careful to use carbonic anhydrase inhibitors. Again, I am repeating why, because normally ammonia is converted into urea, but if your liver is not working properly, ammonia will goes into the urine. Ammonia, because in normal physiological process H positive ions are here, so this ammonia will combine with the H positive and convert into ammonium ion, and ammonium ions are, since it's ionic charge, so it will be excreted out, it will not reabsorb back. But if H positive ions are not available, so it will remain ammonia. So ammonia is not charged molecule, it is going to reabsorb back and reach to the systemic circulations and can cross the blood-brain barrier and can do the hepatic coma, right? So that's why you have to be used carefully with respect to this one. Another problems with these carbonic anhydrase inhibitor is hypokalemia. Even though most of the diuretics will result in the effect of hypokalemia, even your loop diuretics are also results in hypokalemia. Your these thiazide diuretics are also can result in hypokalemia. So there is a potassium sparing diuretics that can retain the potassium. Otherwise, these all are could results in hypokalemia. So how hypokalemia can be formed, right? How carbonic anhydrase inhibitors results in hypokalemia? What happen? As I said, your carbonic anhydrase inhibitors inhibit these steps. So you know sodium and bicarbonate is going down. Next part is your loop of Renals, then your distal convoluted tubules. So this sodium will goes down. So there is a chances for sodium to reabsorb again back to the systemic circulations in the next part of the nephron, because there is a again there is a sodium channels are there. right? So it can be reabsorbed back. So if it will reabsorb back, so it can increase the potassium concentrations and potassium will be expelled out. So that I will discuss in the next next slides, how these drugs like carbonic anhydrase. So question is how carbonic anhydrase inhibitors could result in hypokalemia. How it can happen? So how it can happen, as I said, what happens, your carbonic, these in proximal convoluted tubules, there is a sodium and hydrogen exchanger, right? So sodium and hydrogen exchangers are not working properly, so your sodium will come to the next site, and in lower down your loop of Henels are there, then there is a distal convoluted tubules are there. So there is also a chances for the sodium to reabsorb back, right? So when your sodium is going to reabsorb back in the cells, so what will happen? Your sodium is going to be, so there is a 3 sodium 2 potassium exchanger is there on the basolateral side on each and every cells, right? So किसका है? So as I said, with carbonic anhydrase inhibitors could result in hypokalemia. So how it happens, So as I said, that in proximal convoluted tubule, if you are giving carbonic anhydrase inhibitors, so this channel is going to affect sodium and hydrogens. So what will happen? Your sodium is going to next part, and in distal convoluted tubules also there are cells. If we talk about distal convoluted tubule, if this sodium is reached to the distal convoluted tubule part, so there is also channels which will help in the reabsorption of sodium. Sodium will enters, and in the basolateral side there is a sodium potassium pump. So 2 potassium will come inside the cells and sodium will goes to your systemic circulations, blood circulations, right? So what will happen? This cells is going to reach in the potassium, right? There is a potassium channels are also there that will also do the absorption of reabsorption of potassium ions. So there is a leaky channels for the potassium which will leak out this potassium, and this potassium is going to be excreted out. Simple concept, excreted out, and can result in hypokalemia. And with respect to your loop diuretics also it can be happen. How it's happening? Because in distal convoluted tubules there is a sodium channels, there is a potassium channels are also there, right? Potassium is also there. So what's happening? Your sodium is going to be thrown out from the cells, and 2 potassium is coming in, and here also potassium is there. So ultimately what's happening? This cells is going to be very rich in potassium. So potassium concentrations is very high. So when your potassium concentrations inside the cell is too much, so it's going to be leak out. There is a leaky channels for the potassiums. It can be leak out, and it can be leak out. It will goes to the luminal side, and it can be excreted from the body, and could result in hypokalemia, right? This is the concept how carbonic anhydrase inhibitors results in hypokalemia. Hypokalemia, right? Then there is a we will discuss mechanisms of how these drugs are resulting in hypokalemias, that we already discussed. But what are the next drugs which comes under diuretics, and next drugs under diuretics, the drugs which are acting on the loop of Henel. And in loop of Henels, if you see the loop of Henel, the ion channels on the loop of Henel, this is your, for example, your luminal membrane, so luminal side, and this is your basolateral side, right? So here is also ion channels, sodium potassium and 2 chlorides. 2 chloride, sorry, 2 chloride. 2 chloride. So this is the ion channels on your loop of Henle. Loop of Henle. So loop of Henle. So drugs which is going to block these channels or movement of sodium potassium 2 chloride, these are the diuretics, and these drugs we call loop diuretics. Because why loop diuretics? Because they are acting on the loop of Henle. These kind of the drugs we call loop diuretics. Loop diuretics. What will happen? So your sodium is not going to reabsorb, your potassium is not going to reabsorb, your chloride ions also not going to reabsorb, so it's going to be move further part of the nephron, right? So again, these loop diuretics could also result in hypokalemia, same concepts, right? These loop diuretics can also result in hypokalemia. Similar, because this sodium is going to be, because it's not going to absorb this part, but they can absorb in the distal convoluted tubule part, right? So this is your loop diuretics, that is the most commonly used drug under loop diuretics is furosemide. Furosemide. Furosemide is a drug which is used under loop diuretics. And then the drugs which can act on another part is your DCT, that will be called distal convoluted tubule. Distal convoluted tubule, right? So this is your distal convoluted tubule, for example, last part of your nephron. This is your luminal side, this is your basolateral side. So the distal convoluted tubules have again ion channels, sodium, right, hydrogens, right, potassiums are also there. So these channels which is going to block by the drugs which are acting on the distal convoluted tubules, that is we call thiazide diuretics. Thiazide diuretics. The drugs under this category is chlorothiazide. Chlorothiazides. There are many drugs under thiazides, right? The drugs, the next part is your collecting ducts, right? In collecting ducts, there is a, again there is a channel for sodium ions. Your aldosterone is also acting on this. Aldosterone is the hormone which is released by adrenal cortex, and it acts on the nucleus. It do the expressions of proteins and which do the sodium channel expressions, right? So the drugs which is going to directly block the sodium channel, the drugs we call amiloride. Amiloride, right? The drugs which is going to block the actions of aldosterone, that is we call spironolactone. Spironolactone, aldosterone antagonist, spironolactone, right? These are the drugs which are acting on so on your collecting duct and distal last part of the distal convoluted tubules. So this is all about diuretics. Another class of diuretics is also osmotic diuretics, which will increase osmotic pressures, example like mannitol, right? So we will discuss their mechanisms in upcoming videos in details, and their others details about your diuretics which is acting on loop of Henle's, diuretics which is acting on distal convoluted tubule, diuretic which are acting on collecting ducts. More detail we will discuss in upcoming video. So this is just a general overview about diuretics. What are diuretics, where we are using it? As I said, in various cardiovascular disorders, if you see the treatment of hypertension patients, we are giving the diuretics. These are the first line drugs, right? To the management of congestive heart failure patients, we are giving the diuretics. And diuretics are those agents which will decrease both load, preload as well as the afterload, right? So preload is the load which is created by your blood in the ventricle during the diastole, that is you call preload, and the load which is created by the blood during the contraction of the ventricles, that we call afterload. So both preload and afterload is decreased by the diuretics. So you will find diuretics in most of the prescriptions of the patients who are suffering from cardiovascular disorders. So this is just brief about diuretics and detail about carbonic anhydrase inhibitors. What are carbonic anhydrase inhibitors? Like acetazolamide, what is their mechanism of actions, and what is their adverse effects, and what is their contraindications. So this is all about your diuretics. Thank you. ज़्यादा लंबा हो गया ना, क्या हो गया?